Hi, everyone. Thank you all so much for joining us for this HIV stigma and U equals U session. My name is Laura Gerson, and I will be the AU staff moderator. So if you have any questions, feel free to put them in the Q&A or the chat. And I'm excited to turn it over to our presenters.
Hi, everyone. My name is Murray Penner. I'm the Executive Director for North America at the Prevention Access Campaign, U equals U. Really excited to have this panel, have you all on board, and to share a lot of good information with you today. Thanks to the AIDS United folks for really stepping up and making lemonade out of lemon situation. So really greatly appreciated. I'm going to just kick us off really briefly with a couple of introductions of our panelists, and then we're going to move right into a presentation. I don't want to take up any time with long bios or anything, but I want to say just a few words about all of the panelists. Greg Millett is Vice President and Director at AMFAR, and many of you will know him from lots of research and epidemiology. He was with CDC and with the White House Office of National AIDS Policy, doing a lot of policy work and research work for HIV, in particular among Black gay men. Greg's also a really good friend of mine, and so it's great to have Greg on board. DeAndre Moore is an ambassador for U equals U. He's also a board member with the Prevention Access Campaign. He's a community mobilizer with AHF and an ambassador for Elizabeth Taylor AIDS Foundation. Also a very good friend. So DeAndre, it's great to have you on board.
Thank you.
Next, we have Aline King Carter, ambassador for U equals U, and an ambassador also with the CERO project. Aline is the founder and director of Living in 3D, and is a wonderful friend from Shreveport, Louisiana. She's a wonderful U equals U advocate, and it's great to have her on board. By the way, Greg is in DC and DeAndre is in Houston. We also have a couple of international folks joining us. Charlie Treadway, he's with the National Association of People with HIV in Australia, in Sydney, and with Rainbow Youth. Charlie, it's great to see you. I don't know what time it is in Australia, but hope we're not keeping you up in the middle of the night or getting you up too early. So thanks for joining us. And lastly, we'll have William Matuva joining us. He's a HIV educator and peer advocate from Love to Love organization in Kampala, Uganda. Both Charlie and William will be speaking with us a little bit about their experiences with U equals U in their countries. So we've got a great panel, and I'm going to turn it over to Greg Millett to actually kick us off. Greg.
Great, thank you, Murray, and welcome everybody. I wanted to talk a little bit about the role of stigma in policy and lessons from our past, and how we have been able to turn the corner with U equals U. Next slide. A quick outline of my talk. I'm going to talk a little bit about HIV stigma in the US then, now, what it looks like, some issues with healthcare access for people living with HIV in the US, how the past has become the present with stigma, HIV, and COVID-19 commingling, and how we've been able to own our status and own our truth as people living with HIV. Next slide. So then, what do we remember about what happened then? I think, Murray, myself, and I'm sure many of you who are on this call remember what HIV looked like in the 80s, and how people living with HIV were distinguished from other populations, primarily from KS on the left, or from wasting, or even lipodystrophy for those of us who were taking several types of drugs. So we couldn't really hide who we were. There were visible markers of HIV and HIV infection. Next slide. And the hysteria around HIV and HIV infection, unfortunately, was incredibly high, particularly in the United States, with the tabloids, people who were not allowed to go to class, the way that we were dealing with immigrants, particularly Haitians, who did not have access to donate blood and other services. Next slide. And even just, ridiculous, shocking types of things that would take place. Oh, next slide. in terms of the materials that were being produced in. I mean, these are some of the AIDS prevention materials that were being produced. The one on the left was produced, I believe, in Berlin. AIDS is a mass murderer, shows Hitler essentially raping a woman. One of the ones that we've seen quite a bit of is this man with a scorpion basically saying that you don't know who you're sleeping with, and just the ways that people living with HIV were represented as in terms of being vectors of disease was very much commonplace, both in the 80s and in the early 90s. Next slide. So now, have things changed? Next slide. Unfortunately, not really. I mean, I think many of you remember what happened when Charlie Sheen came out with his HIV status just 2.5 years ago. Instead of the media talking about the fact that, you know, U equals U, or that he was HIV positive and was not able to transmit the virus undetectable, people were talking about which girlfriend might have been exposed to HIV, the fact that he was having to be paid hush money to keep quiet about his HIV status. So it's still something that is seen as a negative to a certain degree. Next slide. And even just last year, when Jonathan Van Ness came out about being HIV positive, I mean, overwhelmingly, the actor from Queer Eye received a lot of positive news and results from people. But there were some people online who were trying to say things that were really derogatory about him and about him dying of AIDS. And it was great to see other people respond online with Twitter and others with U equals U, and just saying, you know, you really need to educate yourself about some of these issues. Next slide. And it's also the policies that we have in the United States. I mean, there was a federal judge recently that was just ruling around HIV positive airmen. The Trump administration was actually trying to kick out Navy officials who are HIV positive just because of their HIV status. It didn't hinder their performance at all in the job, but they were still going to get kicked out because of their HIV status. And it's just shocking that something like that is happening in 2019 and 2020. Next slide. And then, of course, in the United States, we all know that we still have these incredible criminalization laws that are in the books that really came on the books exactly when the hysteria around the HIV was highest in the 80s and the early 90s, and unfortunately have stayed there. So we have, you know, criminalization-specific laws for people living with HIV in 34 states. There have been about 800 people who've come into some sort of contact with the criminal justice system between 1988 and mid-2014. 98% of those convictions didn't require proof of intent to transmit HIV. 93% didn't require proof of conduct that is likely to transmit HIV, and 0 of those convictions actually required actual transmission of HIV as an element of the offense. So it really didn't matter whether or not HIV was transmitted. It's really all about fear and stigma. Next slide. And the CDC has already taken a look at these laws, and they found that objectively, these laws are really not associated with reducing HIV infections. If these laws actually worked within these states, then you would see fewer HIV infections, new infections. You would actually see fewer AIDS diagnoses as well. But when the CDC went ahead and took a look at these data, and they published this a couple of years ago, they found that there was no association and said that these laws really have no effect in HIV prevention. Next slide. Now I want to pivot a little bit and talk about healthcare access and what it means for people living with HIV in the United States. Next slide. We know that there are a lot of benefits to the Affordable Care Act and Medicaid expansion. So we know that ACA enrollment is associated with undetectable viral load. It's associated with increasing HIV testing in Medicaid expansion states. It's associated with a 10-year decrease in HIV diagnoses after Medicaid was expanded in Louisiana just recently. We see 4-fold increases in PrEP uptake among Medicaid recipients under ACA. And we know that sustained viral suppression among people living with HIV is higher in those states that have expanded Medicaid versus those that haven't. Next slide. But unfortunately, in the United States, we still have 14 states that have not expanded Medicaid. And 5 of the 7 EHE states, which you see outlined in yellow before, that's President Trump's initiative to end the epidemic, taking place first in these states in phase 1, also have not expanded Medicaid. Next slide. And what that means for people living with HIV, particularly in those states that have not expanded Medicaid or that are part of the president's plan to end HIV, well, there's some problems that are there because we see that insurance rates are highest for every race and ethnicity in those states that are part of EHE as compared to other parts of the Ending the HIV Epidemic plan. So you see it's highest for whites in those states, Asians, African Americans, Latinx populations, Native Americans, and Native Hawaiians. Next slide. And what does this mean for people living with HIV? Well, we know that there are in excess of 60,000 people living with HIV in those states that haven't expanded Medicaid. And there's data from CDC showing that among all of us living with HIV, that we're not doing that great in terms of continuous viral suppression in the US. So these were data that CDC released 2 years ago, where they found that fewer than 50% of us living with HIV are continuously virally suppressed. And then, of course, they found that there are racial and ethnic differences. So it didn't matter which race or ethnicity, it didn't matter which group by race or ethnicity, but African Americans were less likely to be continuously virally suppressed. Next slide. Let's see, next slide, there we go. Now I'd like to talk a little bit about, stigma, stress, and medication. When you're not continuously virally suppressed, there may be some reasons for it. There are data out there showing that people living with HIV who experience stigma are 3 times more likely not to adhere to medication regimens. And then there's a really lovely study that you see on the right-hand side that a colleague of mine, Michael Mugavero, did in Alabama, where they were taking a look among people living with HIV, the number of stressful incidents that they had in the past year. And as you can see, for those people who had a greater number of stressful incidents, which you see on the bottom, you see that incomplete adherence, not taking your medication adherence actually increase, and it increased in a linear manner. So we know that stigma and stress is associated with not being able to take your medications or to be continuously virally suppressed among people living with HIV in the US. Next slide. So what does this mean as well in terms of the COVID crisis? I mean, are there any lessons that we can learn from HIV and past and present in terms of stigma? Next slide. Well, we know really quickly that the US is not doing too well in terms of curbing coronavirus cases. You can see really clearly here, and this is just from last week, that the US is really at the highest part of the curve in terms of new coronavirus cases, and is not doing as well compared to Spain, the UK, and many countries in Asia, such as South Korea, Japan, Singapore, and Hong Kong, et cetera, that took preventative measures. Next slide. And we know that stigma is also associated with misguided policies, and we're seeing stigma rearing its ugly head again during the coronavirus epidemic. We see that, President Trump moved very quickly to stop travelers from other parts of the world that have coronavirus, without realizing that coronavirus was already here. We were already experiencing community spread here. And it's the same thing that happened during the ban for HIV-positive visitors to the United States many years ago, is that we had this ban in the absence of evidence, and in spite of the fact that HIV was already endemic to the US and here. It wasn't the visitors who were bringing it here. Next slide. And we also know that there's homophobia that's associated with the early parts of the HIV epidemic. Gaten Dugas, who was patient 0, was mainly credited as the person, infamously, who spread HIV as a flight attendant from all across the US and other parts of the world. And we could also see, and this is just part of the transcript from President Reagan's press secretary, that there wasn't really much love for HIV from the government at the time. There was a very slow response with them saying, I hope you don't have it, do you? And it's just really problematic. And people who are saying, do you got AIDS yet, as synonymous with gay. Next slide. And we're seeing the same thing, unfortunately, with coronavirus, with xenophobia on the rise, and a lot of discrimination against Chinese populations in particular in college campuses. We have our president calling it the Chinese virus, which is incredibly problematic, and xenophobia that's spreading all across the United States and in other parts of the world. Next slide. Another comparison that we can see is an echo from our past is testing positive. I can't tell you how many friends of mine that I know in New York who talked about testing positive and how it's giving them PTSD to testing positive when they were first tested positive as HIV. And we're also seeing some of the echoes of the past of what we saw with HIV too. I remember, and many of us on this call remember, that you would go through pages of obituaries in the 1980s and the 1990s with many of the weekly gay magazines. And you can see exactly the same thing taking place in Italy, and perhaps might be taking place in New York within 2 weeks' time. Next slide. And we're also looking at a lot of loss. We're losing a generation of many leaders in the HIV movement, as well as gay leaders. Terrence McNally, the writer of Love, Valor, Compassion, the Tony award-winning play, or play that was nominated for several Tonys, died just recently. It was a play about HIV and how we made it through HIV. And it's sad that people who made it through the HIV crisis are now being felled by coronavirus. Nisham Wooden just passed away last week. Nisham was very famous in the New York City scene. He played as a drag character in some really infamous, wonderful bars and entertainment in New York. And then we also know that the New York City first nurse that died of HIV, of COVID, is a gay man. So we're losing a generation of people as well, potentially, for COVID, just like we did with HIV. Next slide. And then there's also a return to safer sex and a lot of the anxiety around sex that we see with both COVID as well as HIV. And this is particularly problematic for people living with HIV because for so long we've been considered vectors of disease and people really looked at us in really suspect ways. But now you're seeing gay dating apps sort of warning about coronavirus and how to meet people, that phone sex is safe sex, etc. Next slide. And we're also seeing, unfortunately, with all of that, a return to slut shaming. And, you know, there was just recently information that West Hollywood has the highest rate of coronavirus in LA. And there were a lot of people on Twitter saying, what's going on with you guys? You got to get off Grindr. You've got to do better here. And we also heard that there have been thousands of Miami people who went to the Miami Gay Festival, the White Festival, White Party, who tested positive for coronavirus, and many people who've been shaming them for doing that and participating in those activities. Next slide. I think one of the more constructive things that we've seen that's come out of it is the harm reduction information that's come out of the New York City Department of Health saying this is how you should have sex in the era of coronavirus, and being very specific about the things that people should or should not do, which is exactly the types of things that we saw people do early on in the early epidemic, HIV epidemic. Next slide. And we're also seeing this whole issue of Medicaid expansion, where it might even be ironic that we haven't been able to get full Medicaid expansion through the Affordable Care Act, but because President Trump recently announced that this was a national emergency, that we might now get Medicaid expansion in some of the remaining states simply as a response to coronavirus and getting more resources out there for coronavirus. Next slide. So what does this mean for us today and U equals U? I would argue that U equals U is the latest chapter in empowerment for people living with HIV. Next slide. We know that we labeled ourselves as HIV positive in the 80s when it was not safe to do so, with members of ACT UP and others who were very clear about being HIV positive. Next slide. We also know that in the 90s and the early 2000s, there were many of us who were actually tattooing our bodies with various symbols to show people that we were actually HIV positive or radioactive, and new ways to really talk about HIV when turning stigma on its head by essentially reappropriating everything and stigmatizing ourselves. Next slide. We've also seen people living with HIV as well as people who are negative, part of the Stigma Project, just really pulling together some very good and interesting campaigns against HIV stigma in the past decade that I would argue has been much better than some of the work that we were doing when I was at the government, because it's community-based, it's community-led, and the messaging is very clear about HIV stigma and was incredibly effective. Next slide. And then, of course, we have U equals U. It's incredible to me that undetectable equals untransmittable is such an easy phrase to remember things. And as a scientist and epidemiologist, this was something that I knew, but I had no idea that very few people who were living with HIV really understood what this meant. And the way that this has now been democratized for people living with HIV and a source of pride, not only here, but across the world, is incredibly important. For many of us. And I really think that U equals U is also going to be a cornerstone for helping us increase the rates of people who are not continuously virally suppressed, as I showed in earlier slides. Next slide. And because of U equals U, we actually see that we're winning court cases in terms of discrimination for people living with HIV. So just recently, with Trump trying to prosecute these HIV positive airmen and to keep them out of the army, the court basically said that this does not comport with the scientific evidence. The same thing happened with Sanjay Johnson just recently, whose case closed with only a 5-year probation. Whereas he could have been in jail for decades for having sex with somebody and not disclosing that he was HIV positive. But the judge saying that undetectable equals untransmittable, there was no harm that was done, there was no transmission, this is not an issue. So we're seeing that U equals U is actually creeping into policy and actually changing policy in the US. Next slide. And that's it for today. I just wanted to give just a quick breakdown to get the discussion started. And thank you for your time and for your attention.
Thank you so much, Greg. That was fantastic. I think, you know, as you pointed out, there is an opportunity for U equals U to not only help us with getting more people motivated to be on treatment, to argue for the reasons for treatment access so that everyone has that, that right to get medication and treatment, but also to improve the lives of people living with HIV. And so there's just tremendous opportunity. And to kick us off with a little bit more information about U equals U, I am going to turn the conversation over to, is it DeAndre that I'm turning it over to?
Aline.
Aline, I'm sorry, Aline, I got it backwards. Aline King Carter, take it away.
Hi guys, me and DeAndre, my colleague, U equals U ambassadors, are here to speak with you about U equals U. Next slide. So what is U equals U? A lot of people but don't know exactly what the science says and exactly what it is. Undetectable means untransmittable. People living with HIV who are on treatment and have an undetectable viral load cannot transmit HIV. Next slide. Now, why is U equals U a game changer? It transforms social, sexual, and reproductive lives of people living with HIV like myself and frees us from the shame and fear of transmitting HIV. It also dismantles HIV stigma and reduces anxiety associated with HIV testing, and as an incentive to start and stay on treatment and in care to stay healthy. It provides a strong public health argument for increasing access and removing barriers to treatment and care. And the third U in U equals U is universal. Next slide. Now, what are the rules to enjoy U equals U? U equals U is TLC. First, T is for treatment, then L is for labs, C is for connection. If you have less than 200 copies of the virus in your blood, then it is synonymous with viral suppression. U equals U is about sex. And a lot of the people that are against U equals U are talking about breastfeeding and needle sharing. That's not what we're talking about. U equals U is about sex and empowerment for people living with HIV. U equals U only prevents HIV. Now, if you are having sex without using a condom, what have you, that's not what we're talking about when we say the truth about U equals U. U equals U is just talking about preventing HIV. HIV disclosure laws. U equals U might not be an exemption, but it has been used, as my colleague said earlier, in some cases. Now, V is not equal to V. Viral load does not equal value. So just because for different reasons that you cannot become virally suppressed at this time, that does not mean that someone that is virally suppressed is better than someone that's not virally suppressed. That's not what advocacy is. Universal. We demand, not ask, we demand access to treatment, care, and services to ensure everyone can get to U equals U in order to save lives of people living with HIV, which is our personal health, prevent new transmission, which is public health argument, and to end the HIV epidemic. We can't end the HIV epidemic without the U equals U message. Next slide. Public health argument. Improving access and removing barriers to treatment, care, and services. Now, number one, it improves the well-being of people living with HIV, and it eliminates new HIV transmissions. Next slide. Now this, I'm not going to go all the way into it. You can look on the Prevention Access site, but 975 partners have signed on with the U equals U campaign in 101 countries. Next slide. These are some of the health jurisdictions that have U equals U, that have signed on to the U equals U truth and message. If you don't see yourself on there, your jurisdiction, your part of town, you need to fight to make sure that you're on there. Next slide. Now, from 2017 to 2019, the CDC said effectively no risk of sexual transmission when on treatment undetectable. Now, U equals U is 100% effective for preventing sexual transmission. Okay. Their colleague letter came out August 2019. It authorizes flexibility in messaging, including PACS communication. Is when the CC first came out with what they were saying, they didn't have an okay for have you to use the U equals U message. When they came out with that letter, of those colleague letters, they're saying that they could use that in all their different messaging for CD risk. In science, there's no just concrete 0, no percent, but effectively no risk does not mean that you can transmit the virus. U does equals U is 100% effective for preventing sexual transmission. So you should say no risk, 0, no risk. Okay, now we have the last slide. With the coronavirus and everything, he's with the National Institute of Allergy and Infectious Disease. He was one of the first doctors. The truth about U equals U is the foundation of being able to end the epidemic. Next slide. Now, December 2019, DHHS treatment guidelines. All persons with HIV should be informed that RNA viral load of 200 or less copies, including any measurable value below the viral therapy, prevents sexual transmission of HIV to their partners. Patients may recognize this concept as undetectable equals untransmittable, or U equals U. Now, this is Department of Health for the United States, and it came out in December 2019. That's from countless fights and countless information given from advocates like myself. How to communicate U equals U. Am I on your slide, DeAndre?
Now, yes.
Take it away, DeAndre.
I apologize.
It's okay. Listen, hey, you got it. You are killing it. No worries at all. No worries at all.
It all worked up.
Okay, no problem. So I'm going to take over, guys, and then thank you, Eileen, for going over the science and the facts about U equals U. The information that Eileen has shared and that we're both sharing today is going to be available to everybody at some point. We see the questions on the side. There will be time for questions, so don't think that you're being ignored. We do see it, and I'm sure that we'll get to a few of them. If you guys aren't talking, remember to mute. I can hear someone. But when we're talking about communicating U equals U, we're discussing the advocacy, the meat of the advocacy, and how to relate that to other folks, whether it be community members, healthcare providers, politicians, the folks in power. When you're communicating, you have to be sure that there are 4 C's to always follow, and that's being clear, being confident, being consistent, and being conscious of everything that we're talking about. And so I'm going to run through what each of these mean and how to better navigate when you're communicating U equals U, and how to ultimately be a great advocate and to not only advocate for yourself and for public health, but for everybody out there. So the way the risk is described has significant impact for individuals living with HIV and on HIV stigma. Every provider, we believe within Prevention Access Campaign, the folks that are attached to the U equals U movement, believe their language does matter. The things that you say and how you say them leave error for margin of error, and folks have misconceptions about certain things. And so when you're talking about being clear about the messaging, you don't want to say things like negligible. You want to say you can't pass it on, because these are things that we know. You want to stay away from extremely unlikely to just can't transmit. Be very direct, always. And continue. Don't say virtually impossible. You can say no risk. You don't have to say close to zero. It is zero risk. And the information, the data that we have concluded shows that. We have numbers to back this up. And so that's always great when going into an argument about U equals U, and folks who are always on the fence about it, is that we have the numbers and we have the data that proves it. And so instead of saying helps prevent, you can also say it does prevent. There is absolutely no risk when a person is undetectable and they have an undetectable viral load. They're also untransmittable, sorry. And so being confident about U equals U, folks can always tell whenever you're having a conversation, if you're confident about what you're saying. If you believe in it, that you have every right and every reason to be confident about what you're talking about. You don't want to say things like, I believe in U equals U, but use a condom and or PrEP just in case. Because if you truly believe in U equals U, you know that the numbers are right and that the data proves that a person who is undetectable cannot transmit HIV under any circumstances. We're talking sexually, just sexually. That condoms and PrEP aren't needed at all. There's no ifs, ands, or buts. It's about being direct and confident in your messaging. So you can't say condoms and PrEPs aren't clinically necessary to prevent HIV with U equals U when we're talking about sexual encounters. Just want to throw that on there because, like my colleagues have said earlier, U equals U in the science pertains to sex. And so you might want to use a condom and or PrEP and other things. No, you can go on to the next one. So I want to kind of catch us up. And also being confident about it is you want to say things like, you don't want to say things like you're only good as your last viral load. No, being confident means saying things like if you're taking your medication as prescribed and having a regular viral load test, there's no need to worry. You also don't want to say things like you never know, because we in fact do know. As we said over and over, I'm going to keep repeating it, is that the science matters. Being consistent means continuously sharing the message no matter wherever you are, wherever you go. So whenever you're inside of those meetings, whether it's a board meeting, a Ryan White planning council meeting, or anything, be sure that we're being open and honest and consistent about our messaging so that we can continue to see it and we can continue to share that with other folks. People need to hear, see it, and practice it by saying U equals U over and over to accept it and to believe it. Integrate it into patient information, guidelines, clinical rooms, outreach activities, and communications. If you're going to your doctor's office, if you don't see any information about U equals U, I would urge you to ask the healthcare administrator of that office, why is there no materials made available for that? Why is there no messaging around that? And see if they need those materials. Some offices might not have it just because they haven't had access to it. Reach out to one of us at Prevention Access Campaign. We'd be gladly to get some information out there to them. Always have a conversation about U equals U with those living with or vulnerable to HIV at every opportunity, and continue to use social media any chance you get, the hashtags and so forth, and which we'll talk about in a few. Next slide. Okay, viral load does not equal value. Not everyone is able to achieve and maintain undetectable viral load. So although we're saying U equals U, it's important to realize and understand that when you're doing your advocacy, there are still some people who cannot and have not yet reached an undetectable viral load. And so as a person, for me, who does have an undetectable viral load, I understand still both sides because I have friends who do not also. It's important to help them know how to advocate for themselves when they're in those doctor's offices to figure out why is it that I have not yet been able to achieve an undetectable viral load. What's not going right? Is it the medication, the regimen? What needs to change so that I can get closer to that goal? That's a goal in mind, but we also want to ensure that everybody knows that U equals U is not the only thing to make a person medically adherent. Being medically adherent is always the ultimate goal under any circumstances, and whatever that might mean for you or for a person who has not yet reached an undetectable viral load, but is still healthy. Because as we said, viral load does not equal also value. And to share social media, like I said, when you guys are communicating this out there, whether it's sharing a message or any type of post, tweet, whatever, always use the hashtag. We use you equals you. Spell out equals. If you use the equal sign, it won't catch it. So you have to spell out you equals you often. And contact prevention access campaign. We have more than enough social media materials to share with you. If you want to help and jump on board with pushing the messaging and so forth. And so continue to join the revolution. Train your staff in all U equals U sciences and communications. Like I said, if you're not hearing it from your doctor's office, you're sometimes your own best advocate for those people. Ensure that each of them can get a chance to talk about that. Communicate clearly and confidently and consistently with everyone. Go over those 4 C's as we went over just now. Again, this information will be made available to you if you guys need help with communicating this to other folks. And speak out if you see incompetence or inaction, and support positive efforts. So if you're somewhere and a doctor or someone is telling you that they don't believe in it, or they don't want to have those materials made available to their offices, it's important that you contact someone that's over that doctor or leaders within other organizations to help ensure that they're getting that. We cannot let doctors continue failing community members and offices, and community organizations continue to fail our community by not including this information. And advocate you with the public health argument to increase access and decrease barriers. And again, social media, use it, you equals you, we really appreciate it. And so I'm gonna move over to, I think, another slide. Here's the information here. It's time to redefine what it means to live with HIV. Here's Murray, our North American Executive Director's information to the side. You can find all of ours on the Prevention Access Campaign website or uequalsu.org. You can look under ambassadors and find all of our email info if you guys have any additional questions. And as we get ready to wrap up, I'm going to go ahead and just share a little bit about, personally what U equals U has been to me, and how I kind of got involved with the campaign. It's probably around 2015 or 16. I met Bruce Richmond, our founder, at a conference, and this man was just running up behind me telling me about this messaging, like you got to know it, you need to know it. I'm like, okay. He's like, you're attached to so many people who are not picking up this message, but if you truly care about your community, you have to listen to what I'm saying. And I'm like, okay, if somebody can tell me that I have to listen, then I definitely I'm going to take a moment to listen to this man. And we did have a conversation there, and I was starting to get won over. And of course, I still took the time out to go research myself, and I found out that this man who was chasing me down at a conference was actually telling the truth about what undetectable equals untransmittable meant. And it did something to me because I knew I had undetectable viral load, and the messaging, the fact that it hadn't been there, it shocked me. And I was wondering why are other organizations, why are they not sharing this information? And so I remember the summer went by, I called to Bruce again on the phone, and he's like, hey, DeAndre, the organizations that you're attached to basically are still not signing on, and I don't understand why. If you believe it, basically, how can you be a part of something that is not signing on to things that you believe in? And it was almost as if I was being charged that as a leader, I had a duty to speak out and speak up for things that I believed in. There's no way that I can continue being a part of something for name value, but it's not valuing me or my community. And so I became really emotionally attached to this message, because here's this man that I'm seeing chase down and call out everybody who has yet to sign on, who has yet to share this information with their community members fighting. And I have a duty to help him. If we're going to talk about community and access, it's important that we have everybody involved and on board, because as we've seen before, folks have failed us time and time again. But each one teach one. And so reaching out to those organizations, some of them were given ultimatums. If I'm going to be a part of this, these are the things that have to happen. You cannot say that you represent me or you care about me without sharing this information. And so we've seen some changes. I'm excited to keep the ball rolling and continue seeing those changes. But sometimes it also goes back to having to have those hard conversations with people that say they care about us and that are funding us, but are yet to show it with action as well. And so that's how I've gotten here, continue to fight. I'm excited to continue it going. And we've got to continue keeping up the response efforts that we're doing as well for COVID-19. So all of you, thank you. I'm going to turn it over to Eileen to share a little bit, and I think that we're going to wrap it up, guys.
Okay. Let me, because I am a long talker, tell you briefly how I got into the U equals U movement. As DeAndre similar, he came behind me and he was kind of cute. Like, well, he coming up. I know he's not flirting, but anyway, he told me about this message about U equals U, and that he was gonna try and start getting advocates together to try and get the
I don't think I was hearing you, Eileen. There we go.
can you hear me? Can everybody hear me? Okay. I was trying to understand would tell the truth about what was going on. And so he asked if some of us would get together, which we did form the steering committee after that, get together and do a video. And Carrie Foote in Minneapolis and a couple other people, you can see the video on our preventionaccess.org. But we got together and we sat and we got our telephones and we filmed our truth that U equals U, the science is out there, and if you're not going he was very deliberate talking about his privilege as a white man, and he said that he wanted to make sure that he used that privilege so people of color, brown people, black people, everyone could get the message. And that's what we all value. So that's how I got started in advocacy, and it's grown from there. A lot of the outside countries have been doing a lot of work, but United States needs to step up. We need to step up. And like I said, if there's any other questions or anything that we need to talk about as far as on one-on-one, the information is on www.u-u.org or prevent to answer any questions you have. I turn it over to my other colleagues.
Thank you, Eileen, very much. Now we're going to hear from Charlie from Sydney. So Charlie, thanks for joining us. Welcome. You're muted.
I'm unmuted now. Thanks for having me at this early state of the morning, but happy to be here. Next slide. Thank you. First of all, I'd like to acknowledge the Gadigal people of the Eora Nation, where I'm joining you from, and pay my respects to elders past, present, and emerging. I'd also like to acknowledge that this always was and always will be Indigenous Aboriginal land, and that I am a guest here where I live and where I'm joining you from. My bio's up there. I'm not going to speak to any of that. I'm going to speak to something personal. So I have been living with HIV for 14 years now. And when I was first diagnosed, it was a different time for HIV. It was sort of a revolving door at the clinic. And so they gave me my results and told me to hold off starting treatment for as long as possible, and then sent me away with no support. I thought that that meant that I didn't have to start treatment and that I could carry on living my life as per usual. Fast forward 7 years where I had drastically mismanaged my health, and where I was, if I had have been in America, would have been diagnosed with AIDS. In New Zealand and in Sydney, it's about a level of opportunistic infection that you have, not necessarily about a CD4 count. Which is proof that wherever you're living in the world, it has a different context or a different measure or different things that need to be communicated. It's taken me quite a long time to get a foothold on my health. I've sort of devoted all of my life to that, and I decided to become an advocate so that other people weren't falling through the gaps in the system. I am really pleased to say that after 14 years, last week, I just found out that I had finally reached an undetectable viral load. So, yay. Pretty happy about that, and what a way to celebrate that by joining you here. Next slide, thank you. So I'm here to talk about an abstract that was delivered at CROI, and it's talking about how HIV incidence fell through treatment as prevention, through U equals U, long before the introduction of PrEP. That was sort of happening before the introduction of PrEP. It's something that doesn't get talked about a lot. We know that PrEP is the big thing, or in New Zealand, what we have is called, you know, sort of above the line marketing, which they target PrEP in the community, and below the line marketing. So things that pertain to people living with HIV usually get pushed below the line in terms of the community response, and that's unacceptable. Next slide, thank you. So from the abstract, it says that considerable public health resources have been dedicated to implementing HIV treatment as prevention in an effort to reduce new infections. Although promising, no large-scale studies have yet evaluated the community-level impact of treatment as prevention on direct measures of HIV incidence amongst gay and bisexual men. This was in 2012 when this study first started, and it ran until 2017. In Australia, PrEP was sort of wildly introduced in 2016. So that goes to show that, you know, this is something that we have known for years as HIV positive people, that having a low or an undetectable viral load means that you cannot pass on the virus. It's something that we've known anecdotally for years. It's just that the science and actually the organizations haven't really caught up until very, very recently. Next slide, thank you. For 2012 to 2017, we established a longitudinal cohort of HIV positive and HIV negative gay and bi men using data from a targeted sentinel surveillance system, which I'll speak about later. 49 sexual health clinics, general practices, and community HIV testing sites and hospitals. To account for the introduction of HIV pre-exposure prophylaxis in 2016, the analysis was repeated for the 2012-2015 period only. Next slide. The authors demonstrated that between 2012 and 2017, there had been major increases in the treatment uptake for HIV positive gay and bisexual men, with subsequent drops in viremia. A significant point is that the relationship existed prior to the introduction of PrEP in these Australian states. So this study is looking at New South Wales, it's looking at Victoria, two of the most heavily populated states in Australia. It suggests that Australia's investment in treatment as prevention, or U equals U, generally seems to have had public health payoff. Next slide. So what works? This data is only able to be collected and analyzed because we have a really good and stringent surveillance and data collection system through the Australian Access database. Now we know that when it comes to people living with HIV, information sharing and information gathering is obviously a really sensitive subject. I work for an organization called the National Association of People with HIV in Australia. And we sit on these panels. So we sit on steering committees for the Access database, and we make sure that information is being used for what it is meant to be used for, which is getting a handle on the virus in our country and getting a handle on new notifications and how to best sort of target that spear point so that we're responding where we need to. This data gathering thing captures information from state, Some of the smaller states, such as Australian Capital Territory and Northern Territory, they are grouped with their nearest sort of neighbor. It captures information about gender, sex, year of first HIV diagnosis in Australia, exposure category, the 5-year age group at HIV diagnosis, and information around testing. And also CD4 counted HIV diagnosis, which is generally speaking a marker of, you know, how long they've had HIV. Next slide. I just wanted to quickly run down what works. So we have 2 peak bodies in Australia. We have an Australian Federation of AIDS organizations, and their members are the AIDS organizations in each of the states, such as ACON New South Wales. They also have ANA, which is the Aboriginal Network for AIDS, AVIL, which is in directing drug users, NAPWA, our organization, sits on that as well, and Scarlet Alliance, which is the sex worker peak body. Next slide. As you can see here, there's also a ton of affiliate members, but the ones that I want to focus on here are Arches, Burnett Institute, Kirby Institute, and ASHM, which is the Australasian Society for HIV, Viral Hepatitis, Sexual Health Medicine, and also the Doherty Institute, where they're working on cure research. So these are all like scientific organizations that also sit as affiliate members under this AIDS organization sort of peak body. And that means that they're help steering the conversation. We're making sure that there are best practices in place. We're also making sure that science is tailored and that messaging is tailored. We're also able to hold doctors and medical practitioners to account when they're not sharing this information. It is our truth and we need to share it, and if they don't want to listen, we'll kick in the back door. So this is the organization I work for, which is the National Peak for People Living with HIV. And so once again, we have all of the state-based HIV organizations, but we also have associate members. So we have associate members in New Zealand, we have associate members in Papua New Guinea, and like different subgroups. Next slide. So, oh, no, that was back. Forward. Okay, perfect, thank you. So what does the study matter? There's been a divide between some PrEP advocates and the PLHIV community with, for want of a better term, a pissing battle over what has and hasn't contributed and what is important going forward. You know, PLHIV bear the burden of stigma in our communities, and we have always been at the forefront of advocacy and education. Our bodies have literally been on the line to advance science and community perception and educate people. And yet anecdotally, stigma and a serodivide still persists, even from PrEP users. And that's quite frustrating for a lot of people in the community. These interventions are most valuable as a tandem deal and making them accessible at scale. Putting one above the other in a response does a disservice to public health. Both movements are about untangling fear and shame for empowered, healthy communities and people. And when we ignore or deprioritize the impact or engagement of a group, it creates space for people to fall through the gaps in the system. Thank you. All done.
Thank you so much, Charlie. Sorry to keep you moving.
That's okay.
We've got about 10 minutes left, and I want William a chance to talk, and I'm hoping we have a few minutes for questions. So William, I'll turn it over to you. I think you're muted, William.
Hope you're doing well. By names of Mato William from Uganda, and I work with the Love organization. And I'm very, very sorry to come in late because of some issues as far as the country lockdown is concerned, because I've been at forefront to fight for people living with HIV to access treatment. So that's why I've been on phone calls since morning, trying to find ways of people getting their medication. So even I didn't arrange myself well so that I can do a presentation very well, but I have to give some insights since as Love organization we've done the You Because You campaign. So as of now, I would like to share some insights with you guys. When we began, I want to share the insights of 2019, how we have been moving with the campaign here in Uganda. So in 2019, we have been moving around schools, educating students about the You Equals You message. We tried even to go around to educate police women and men about the You Equals You campaign. And we had a very amazing conference, the first You Equals You African Summit, which took place in February 2019. And we had around 100 participants who really admired and took over this message to their respective communities. And here in Uganda, we have been battling with a lot of stuff as far as spreading this message is concerned. But I'm saying that I and my colleagues, I'm saying that we have done a wonderful work here in our home country. Many people now have started knowing the You Equals You message and putting it into practice. So a lot has been happening here, and I'm very, very grateful for Prevention Access Campaign support. You have been so supporting us in this journey since we began the You Equals You campaign here in Uganda. So I'm really very, very grateful. Here we are facing a number of challenges as far as spreading the You Equals You message is concerned. Basically here, people, the leaders that we have here in Uganda already, some of them, they don't want to spread this message because they think that this campaign is promoting those people, people who belong to the LGBT community, which is very, very wrong. And they also think that You Equals You is promoting condomless sex, making in that they are making this that we are trying to make people to become reckless about how they live sexually, which is not right. Even last year when we organized our conference, we noticed that whenever we invited the people from the government, they thought this conference is all about people who belong to the LGBT community. And we have realized that, so it's really, really challenging here in Uganda. Hello, sorry for the inconvenience. Somebody has been calling. I'm using my phone. So I was trying to say that for us here in Uganda with my team, we are committed to spreading the You Equals You message without fear or favor. Thank you so much for listening to me.
Thank you very much, William. Great perspective from Uganda. And I'm very, very happy that we had a couple of international examples today as well. So with that, we are just about nearing the end of our session. Moderator, Laura, do we have any questions that you'd like to sum up?
Thanks everyone for joining. Unfortunately, we only have time for, it looks like one question. So anyone who has further questions can reach out to the panelists. But the question we can ask is, So U equals U is having people freak out over a single test result with a number. Under 200 is still virally suppressed and unable to transmit per the CDC website. Why not include this under 200 clarification more often?
I'll take a shot at that. Thanks for that question. And I've seen quite a bit in the chat about the level of detectability. When Aline or DeAndre, I can't remember who, Aline was talking about the what is undetectable equals untransmittable. That number is 200 copies. And that comes from the studies. The studies were based on 200 copies or less. We know that particularly in the United States, most of the tests that we have available will detect levels below that. And so you may show up as detectable on a lab test, for instance, if you have 100 copies, but in terms of when you transmit, it is over 200. And so if you're under 200, you are still within that level of undetectability and untransmittable state. So it gets confusing. We do include that 200 copies in all of our presentations. You saw it when Aline did the presentation about treatment labs and connection. You see it on your screen right now, up on the right-hand side where it says 200 copies or less is synonymous with viral suppression and thus not transmitting HIV to your sexual partners. We will continue to emphasize that, and we do in all of our materials. So please know that that 200 threshold is the level, and that if you're under that level, you shouldn't be too worried. Now, obviously, if it starts creeping up, and that's why you need to stay engaged in care, that's when you work with your provider to make sure you can get that number back down. The last thing I want to emphasize, and I know we're out of time, is that, again, viral load does not equal value. It's really important to know that people who do have a viral load that is detectable have options to keep their sexual partners safe as well. There's PrEP that's available for their partners. There are condoms that are available, and everyone that comes to this conversation, all people living with HIV, are valuable and important part of the conversation, and important part of using U equals U as an argument to improve our lives and to prevent new transmissions. So with that, I'm going to stop. As Laura said, thank you all very much for joining us, and we're all available if you have questions.
I wanted to take a moment to thank all of the presenters today for doing a wonderful job. This was incredibly informative. And please stay tuned. We have some more sessions coming up at 4 p.m.
Thank you, everybody, for joining us. Appreciate it very much.
Thank you, guys. Bye.
Bye.